Thank you so much, Wendy. It's indeed a privilege to be here. Spent quite a bit of time here once many moons ago, and I was getting my courses under my belt for an MPH at some point. So glad to see fellow folks in that arena. I'm just going to start off with the title for a moment, because it was many decades ago that I was first introduced to the fact that there's no truth in advertising. Does anyone besides me remember that blurb about promise her anything but give her arpege? I always wondered why anyone in their right mind would want something that smells when there's so many other wonderful things out there. Well, when it comes to health data, it's not that the data is bad or that it smells in any size, shape, or form. It's just that the promise is so much greater than the substance right now. So I thought it would be important for us to talk a little bit about all the different types of health data that's out there, and to talk about what the future is going to be with respect to your research as time goes on. How many of you have actually worked with health data claims? Not many. Okay. Well, I'm going to talk a little bit about those for starters. We'll talk a lot about electronic health records and the data that's hidden in there, locked up, shall I say. We'll talk a little bit about some of the data that's also siloed in public health agencies, though you probably know a lot about that as well as public health. We'll touch a little bit on patient-reported data and social media, but I'll spend, I think, the real brunt of what I have to share with you today about why you can't get to it and what the hope for the future is. So starting right off with claims, it basically is composed of some pretty basic stuff, such as patient demographic data, diagnoses. It has what has been done to whom, even if it's just an office visit, and when, as well as by whom, and what was paid for that by a third-party insurer. It does include information on prescriptions filled, and as long as they've been paid for by a third party. So it's got a pretty robust view of the health care you've accessed. And I think it's sort of interesting that a lot of the general public have no idea that that data exists now and has existed in those formats as claims for several decades. I will say that the information on claims does not include why a service was provided or any indication of the severity of a given illness. Now, it can be inferred in some circumstances. For instance, if a 25-year-old female presents with a diagnosis of rheumatoid arthritis and she has gotten a lot in the way of immunotherapy, then that's a pretty good indication this is someone whose disease status is pretty severe. As opposed to a 70-year-old woman who has one diagnosis in the system and no therapy to go with it. Under those circumstances, I would almost bet you that the rheumatoid arthritis isn't even the right diagnosis. It's probably osteoarthritis, but that's not what today is about, so we won't go there. The uses of these claims are quite varied. For the longest time, the insurance business has considered claims to be their treasure chest, and a very proprietary treasure chest. They do not share their claims with, or did not share their claims with anyone else. And they use them to look at total cost of care. They use them for, and I'm going to put this in quotes, quality metrics, because there are some measures of system effectiveness of making sure people get the care they need. But if you really want safe care that is given at the right time, it's timely, and it's all of those things that the IOM talks about as being good care, the quality metrics we have in place don't measure that right now. So I'll just lay that right on the line right now because I'm pretty biased about it, and we'll leave it at that. But the other thing the insurance companies were using this for was to monitor utilization patterns, and they also do something called predictive modeling. They use the data to get some sense of who's likely to be a high-cost patient in the next year or two, and then they do some program planning around that. You can also use the claims data for program evaluation. Suppose you do put one of these care coordination programs everyone's talking about, and if you don't know about them, I'm more than happy to talk about those later too. you put one of these programs in place, there's going to have a cost associated with it. So you really want to know whether the cost is justifiable with the savings that's accrued, and to whom do the savings accrue. If all of the savings, if the cost goes to a provider, i.e. a physician or a hospital, and the savings accrue to the payer, there's a bit of a problem here. So there needs to be some recognition on how the cost is shared, or the savings are shared. And we'll talk again about that in a little bit. The data can also be used for care pattern evaluation. Is it more cost effective to provide a lot of PT to someone with back pain, or is it more cost effective to send them for an MRI and then surgery long term? And more recently, claims data are being used for two relatively new uses. One of them is to develop alternative payment strategies. I'm sure everyone in the room is familiar with the fee-for-service model of clinical care payment reimbursement. As a clinician, you would come to me, either you or your insurance coverage would pay me for every little thing that I do. The visit, the lab, da-da-da-da-da-da. Under the new models, these alternative models, I would not get paid for everything fee-for-service. I would get paid for a bundle, or I would get paid by a diagnosis, an episode associated with that. And determining how you build an episode of care, whether it's around everything from conception to postpartum care, or around the treatment of back pain, requires this claims data. So it is now being looked at very carefully for these alternative payment arrangements. And there's one other thing that's really quite useful. I'm sure you've all heard about in the healthcare law, the healthcare reform efforts that are going on in accountable care organizations. And if you haven't, that's another talk for another time, Wendy. The accountable care environment literally holds a provider group responsible for the total costs of care incurred by the patients to whom they are assigned, or are assigned to them. And they're also accountable for some quality metrics as well. But in that situation, you want to keep your patients pretty much within your own bailiwick, within your own environment. And there are no rules to keep those patients in that environment. You don't have any idea when they're going off and getting care someplace else. So we used to call it leakage in the old days, when patients would go off the range, go off the ranch, so to speak, and go get their care at the Leahy or out the Mayo. Now we call it keepage, because you want to keep everybody on the ranch, and you want to do that by good customer service, et cetera, et cetera. But you have to know where your keepage and your leakage are. So that's a good claims is where people are going for that now. There are limitations to the claims. You know, there's a huge lag time. It's at least 3 months, and mostly 6, before the claims become available. So it's only for retrospective analyses, not for current or prospective analyses. There are issues with coding validity. Used to be that at least 20 to 25% of all claims had the wrong diagnosis on them, which rendered them pretty useless, actually. EHRs have improved that to a great degree, but there are still a lot of issues around diagnoses. As I mentioned earlier, there's no severity of illness, so diabetic is a diabetic is a diabetic. And the diagnoses are based on a system, an international classification of disease system that was devised internationally for epidemiological purposes. They were hijacked for payment purposes when this country started having payment, the fee-for-service system being put in. And they have always been a little bit difficult to really use for anything other than payment and epidemiology. However, the rest of the world has gone to the latest version, ICD-10, within the last several years, while we're still on the 9th version. Though by law we have to be on ICD-10 by October 1st, 2015, which means that we're going to go from 17,000 codes to 155,000 codes. This is driving the delivery sisters and the payers slightly crazy. They have to do it. They know they have to do it. ICD-11 is coming in a few more years. They kind of thought, well, let's just wait for ICD-11. But the outcome of all of this is that all of these changes in the system are making coding and making the use of claims a lot more complicated. The providers are, in general, doing here what they've done in Europe, which is to basically just map the 17,000 codes they used to have to the 17,000 most likely matches out of the 155. So the people who thought they were going to get more information out of this probably aren't. But there you have it. It's just another one of many, many requirements that are being put on all of the provider and payer IT community right now. I would also say that there's one other problem with claims if they are adjudicated by the individual payers, who I said before were quite possessive and proprietary about their own claims, and that those are the usual problems you have with a small n. So if they're really looking at different providers and trying to assess their quality metrics or costs, whatever, they're really not very reliable from that perspective. So to deal with all of that problem, the concept of an all-payer claims database was born, about 2001. Maine was the first state to have one, and now there are 12 states who do. All of the New England states, New York is implementing, and there are a few out west. These all-payer claims databases generally have both Medicaid and Medicare claims in them, in addition to a compilation of all of the commercial claims. So they're very robust and can be very useful for a lot of, and much more reliable for the kinds of things that I talked about a little bit. I will also say, however, that the states who have them are very nervous about them. Most of the states use them only for canned reporting internally. There are a few states, Massachusetts being one, in case you've seen the signs on the T, that talk about transparency of cost. So you can go online and find out where you can get a cheaper, CAT scan, as opposed to a more expensive CAT scan. Of course, it doesn't talk about what your particular copay might be in the two different places, and the savings may not accrue back to you, but at least you have an idea of who provides a cheaper CAT scan. There is the opportunity for organizations like yours that are academic and have IRBs to actually go in and do research. You have to go online to these APCDs, and you can then describe your project. You have to fill out all the forms appropriately and make the application, and you can use them for research purposes. And there's even one, of course it's Massachusetts, I love this state, that will allow the accountable care organizations that we have here. And you probably don't realize this, but close to 70% of the population is in accountable care organizations, which means you probably are too, whether you know it or not. But your providers can go into this database and see where else you've gotten care and how much has been paid for it. So that's the background on claims data, and I don't want to leave this particular slide without at least giving some nod to some of the federal sources of data as well. There are the HICCUP, the Healthcare Cost and Utilization Project out of AHRQ. There are those data, and they include pretty much everything that's in claims, plus a little bit more. It's inpatient as well as ambulatory surgery centers, so it has some characteristics about the site, the length of stay, also has some information on discharge status and comorbidity. However, if you use that data, you have to make sure that all of your reports are anonymized. There's no way to identify either site or patients. And then, of course, healthdata.gov has 1 million or 1 billion, I don't know. There's so many reports on there that you pretty much can do all your background research looking for data there, and I'm sure you know that as well. I do want to say one thing about Medicare claims, however, and that has to do with the fact that those claims were not available to anyone until fairly recently. You could not go into those claims in general, unless there was a very specific project that the feds wanted you to do for them. More recently, Medicare claims have, as I said, been part of and been contributing to the all patient claims databases. Behavioral health claims were included as well, but got pulled out. And there's a lot of discussion about getting them back in. There's this ongoing problem that I think a lot of people have, not recognizing that the brain is an organ, just like a liver or a kidney. You know, it functions based on cells and how the mechanisms of those cells interact with respect to the genomes and everything else that's in the cell, and I won't go there either, except to say there is a tremendous amount of research being done on how these cells communicate right now. And the concept of separating out behavioral health and physical health was essentially undercut with mental health parity when you had to pay for them the same way. But it's still very, very real in many other venues. So people still think that there is a difference, but just remember, we all only have one brain, and it's one organ, and it functions just like all the other organs we have, maybe on a slightly higher level. Now, the issue around access of these public sources is primarily around the fact that every state is different and has different rules with respect to getting to claims data. And the feds have their rules as well. So while there's a tremendous amount of research that can be done using claims, they're out there, they're real, there's a lot of promise to them. You will have to do some digging to get there. Now, everyone thought that the real big promise was going to come from electronic health records. It's reasonable. I'm going to just chat a little bit about, and this is really chatting about electronic health record systems, because in the beginning, they were, with the exception of places like the Brigham, the General, Duke, Vanderbilt, that built their own really nice systems for patient care. In the beginning, the commercial systems, electronic health records for use in particularly the ambulatory space, were designed to maximize reimbursement. They were not designed for patient care purposes, though they had to do some of that for patient care purposes. But the fact that they were designed for reimbursement meant that nobody really knew what they did other than that. So in 2004, there was a certification commission that was put in place that would test these EHRs so that you would at least know that they performed a set number of functions. You knew that they did e-prescribing, that they did patient lookup, and a whole bunch of other things like that. What they also did was check and make sure the system was secure, which was good. What they didn't do was do certification for what we call interoperability, the ability to share health data between one system and another system. And I'm not just talking about one EHR to another EHR, I'm talking about an EHR to anything. And the reason that there was no interoperability at that point was because the feds in their infinite wisdom had decided, back in that era, that they needed to be at the forefront of determining interoperability standards, and we'll talk about standards again in a few moments. So there was no interoperability. In 2010, there was a big change in how certification was done because meaningful use came to the fore. How many of you know about meaningful use? Not many. Oh my goodness. Okay, little digression over here. Meaningful use was slated to be a $45 billion program that would support electronic health records in the delivery system, as defined by eligible professionals, meaning docs and nurse practitioners, and hospitals. Left out long-term post-acute care, left out behavioral health, there's that division again. two brains. People think we have two brains. And basically created a situation where to get the money for as a meaningful use provider and to move forward is get your chunk of this 45 billion, which is now down to much less than that, I might add. You had to have a particular ONC, Office of the National Coordinator, certified EHR, which was certified to support meaningful use measures. And those meaningful use measures were always, I know I sound a little biased here, but I am, of assuring that the federal government could get the data it wanted to evaluate the delivery system, and population health. The systems were not designed for patient care purposes, as docs quickly found out. Many of them turned out to be quite problematic in the delivery system, and in fact the whole program is quite problematic. We've been through stage 1, where a lot of docs have attested and they've received some money, and a lot of literally every hospital that has chosen to do meaningful use, and most of them have gone through stage 1 and have gotten the first trove of money. There's a second trove that's due to come very soon, and unfortunately the delivery system is giving up on it at this point. So what the feds are going to do about meaningful use stage 2 and stage 3 is still to be determined. There is hope that they will delay stage 2 so that the added work of getting the systems done and getting the measures in will be not as time consuming and not as onerous on the delivery system, but we shall see. The parts of meaningful use that are relevant, I think, to you are the following. Number one, when it comes to moving data from one place to another, there is built into this certification process the guarantee that there's a transition of care document. That transition of care document has on it in very clear data standard form information on your problems, your medications, and your medication allergies. Everything else is a non-standardized data format, meaning the only way that it can be used is if you open it up and view it. You cannot incorporate those data pieces if they go from one provider to another provider into the second provider, receiving provider's EHR, except for the 3 things I mentioned. The other thing that's important for you to know is that there are some public health measures associated with this. One is syndromic surveillance, another is immunization, and then a third is referable to hospitals who have to report public health lab data. Now, again, the certification program doesn't mean that you have to actually transmit the data to your public health agency. It simply means that your EHR can pick the data from various sources and package it. Every state right now has a whole different way of accepting public health information data. And I will tell you that, because I spend a lot of time with vendors in my life, is that the last thing they're going to do is to create an interface with 50 different states to get that data to them. So there is really no information flowing to states right now in terms of their public health departments on either of these 2 things. And if it is, it's in pilot form and certainly not very useful for anything other than the pilot documentation. But meaningful use also has a big emphasis on these quality metrics, so we talked a little bit about those. And some of the vendors have even developed what are called their own HISPs, or health information exchanges. Big here in Massachusetts. Epic is a big EHR. It's being implemented at the General and the Brigham, at all of Partners. It's at Atrius Health. It's at Reliant Health out in Worcester. It's at Cambridge Hospital. It's going to go into Mount Auburn. So Epic has pretty much taken over the world with respect to integrated delivery systems with hospitals. And it is very clear that if you just buy Epic off the shelf, you can communicate data with other Epic users. However, I have yet to meet anyone who buys Epic off the shelf. They all customize it. So I can also tell you, the Cambridge Hospital cannot share information with Atrius Health. And Atrius Health and Reliant Health were supposedly coming together in a merger. Two great big huge physician groups coming together. They were both on Epic. Good thing they didn't spend too much money on the interface because they've split up, but they couldn't communicate on Epic either. So, you know, even the promises here don't necessarily deliver. So hopefully we'll get to the point where we'll have good health information exchange, and we'll also be able to use information coming in from remote monitoring devices to do that. I'm not going to say anything about the social determinants of health because you probably all know more about those than I do, except one thing, and that is when I was on the ACO work group, it's a federal advisory committee making recommendations to the feds, we talked about the fact that if these accountable care groups are going to be accountable for the care and the cost of their patients, and we know that health, frankly, is only 20% determined by the healthcare delivery system, then they have to know a little bit more about some of these other things. So there is an expanded IOM initiative to really understand what are the social determinants of health that are going to be really important for the delivery system to be engaged with going forward. And then again, there are lots of other uses for this, but as I say, that's something you know a lot about, and I've already talked a little bit about the public health data coming out of EHRs and as registries as well, so I'm going to skip this too. And just make a few comments on patient-reported data and social media because it is so much a green field and an area where I think we're going to be seeing a lot more effort going forward. Many of you probably know about PROMISE. Those are the patient-reported outcome measures, information system that's out of the NIH. They're research tools that allow you to pull information. They are not linked to anything. They are not linked to EHRs. And unfortunately, the folks who are determining what EHRs are going to do and how they're going to move forward are much more inclined to, even though Francis Collins is on the board of PCORI, they're much more inclined to ignore NIH and go with what's called the PCORI Initiative. That's the Patient-Centered Outcome Research Institute that was formed by the ACA and is a non-governmental, not-for-profit that's doing most of the comparative effectiveness work that goes through, which means that it's a pass-through from, or AHRQ is the pass-through to PCORI, and then PCORI sends out the grants all over the country to do the comparative effectiveness work, and patient outcomes is a big piece of it. If you don't know about Patients Like Me, check it out on the website, patientslikeme.com. It was developed in Cambridge, and it is one of those places where if you have a particular problem, whether it's ALS or you think you have Alzheimer's, you can go. And it's a huge social networking site where people share all their information, knowing full well that it's funded by the drug companies, and the drug companies are using that information in their development process. But because so many people use it, and they're very open about their outcomes and what's going on with them, it's become a big research center for the drug companies. And then there are companies that monitor Twitter and can tell you when there's a GI bug going on around town, and where exactly it started. Did it start here in this part of town at one of the restaurants in the South End, or did it start up in Cambridge? So there's a lot that's happening in that arena just to be aware of in terms of really cutting edge, out-of-the-box research. So let's get down to the last sorry, I got 5 more minutes, so I'm going to try to get down to brass tacks in 5 minutes here. There are 2 big issues when you want to access this health data. Everybody knows about the privacy issues. And the HIPAA privacy rule, different from HIPAA's rule on administrative simplification and security, governs a lot of that. And you, again, if you don't know about that, you will know about that just by the fact that you're part of this group. CFR 42 is the rule that's very specific to substance abuse data. Made it very, very administratively burdensome to share that data from one provider to another. The only thing I want to leave you with on this is that it is being rewritten as we speak. So we don't know what the outcome is going to be, but there's been a tremendous amount of pressure on SAMHSA, the Substance Abuse Mental Health Administration, to modify 42 CFR. It's been around since the 1940s. And then, of course, every state has its own regulation. I'm going to end with really the technological issues of what's going on right now and why you actually can't get to the data you want. You can certainly, as a patient, can go in, and if your doc has an EHR, you should be able to see some critical elements, but why you can't get it as a researcher. It has to do with the fact that there are multiple problems with standards, governance, and consent management. When it comes to standards, there are some basic types. They're the vocabulary standards. Now, there's a diagnosis of diabetes. SNOMED has one way of characterizing diabetes. ICD-10 has another. So what the feds have done is basically said you have to do it both ways in an EHR. You use ICD-10 for payment purposes. You use SNOMED in the problem list. So EHRs have to do this, but you need to know that there's different ways of using those vocabularies depending on what you want them for. The second type of standard has to do with messaging, how you package up and how that particular data is contained. HL7 does a lot of that packaging, and there are other ways as well. But there are multiple organizations that do this, and you have to have one clear messaging standard. Transport, how it actually gets from one part of town to another part of town outside of the particular organization you may be in. There are no standards for that yet. They're still working on them, but there are no standards. So who wants, not too many people really want to get into this ball game, knowing that if they get in with one standard, they may have to pull out and do another. There are, of course, security standards. I've mentioned those before. And then there's also implementation guidance. That means that the receiving EHR has to configure itself in such a way in order to be able to accept the data when it comes in, even if it did come in. So this is a very complicated process of which we have very little in the way of agreed upon national standards at the moment. The problem is that to develop a standard, you have at least a 2-year cycle, because you've got to develop it if it doesn't exist. You have to ballot it through one of these standards development organizations, and that can take up to a year. And then you have to mature it. It has to be out in the environment and in use for a year before it's mature enough to make it a national standard that everybody has to go with. So I wouldn't hold my breath on getting a lot of the data you probably would like to get out of data for research purposes just now. There may be some support coming from the various health information exchanges. They have to work out their own standards with master patient indexes and provider IDs and a few other things, consent management and governance processes. But there is hope on the horizon. Whoops, I keep pushing the wrong button. October 15th, last month, the feds dropped their first draft interoperability roadmap. Now, I have to preface this by telling you that in 2004, there was an executive order that basically said by 2014, every single one of us would have our data in interoperable electronic health records that we could access. That was 10 years ago. You will note the dates on this roadmap. It's 10 years out. And the critical points here is that we're not going to see much, frankly, until 2020. They're working right now on providers and individuals using and being able to access a basic set of essential health data. Researchers generally want a lot more than that. By 2020, though, there will be the ability to access in a granular fashion parts of the data. So it's not like you go into someone's record and you see everything. So there can be, it's segmented data and granular consent, with a lot more in the way of data coming. And then somewhere down the line, 10 years from now, which, it's always a fantasy. 10 years from now is always a fantasy to me. Life changes so much. We're supposed to be having all of these other wonderful things. Now, the hope for the research community is they actually refer to the research community in this roadmap. Talking about between now and 2017, you could access aggregations of this limited data sets which have not yet been defined in pilot projects. By 2020, you can access a lot more data, not for pilots, but for your ongoing research. And then, in the very end, you can do lots more with this for research in multiple sizes, shapes, and forms. How do you get there? Well, you got to be part of the game here, and that's my take home to you all. No matter where you sit in this, is that it will get done to you if you do not become part of the process. So it's a little bit like voting. If you don't vote, you can't complain about what we got. So at this point, there is a lot of opportunity to engage in the roadmap discussion on interoperability with feedback either directly to ONC. There's a place at the www.healthit.gov website where you can give them feedback, and they ask very specific questions. They want feedback. Or you can do this through some of your organizations. I think the American Association of Public Health is meeting in New Orleans soon, so that would be an opportunity to have that discussion and have them go forward with something. And you also, as a community, need to really identify what you can contribute to the sustainability of this. Nobody wants to pay for it. Everybody wants it. No one wants to pay for it. But when you think about what it costs to do research, and if you can get the data you need in this much more efficient way, it's a win-win for everybody. And then ultimately, there is a governance process that will be being set up. Be part of that process. You're an academic institution. You are a public health institution. There are multiple ways that you can be part of that governance process, if not on the overarching governing board, then on all of those myriads of work groups that will be necessary to move this forward. So I probably went over. I apologize, but I do thank you. And it's always a bad thing to be between someone and lunch. But if someone has any questions, I'll be more than happy to try to answer them, either now or during lunch. Please.
So you identified a lot of trigger items. No one wants to pay for the system, particularly when you get down to the nitty-gritty electronic health systems. If you don't have a John Malumka and partners pushing for it, a lot of small offices, I think for a while there, Sam's Club was going to roll one out, if I remember correctly.
eClinical Works it was.
There you go. And no one really wants to pay for this. So everyone was looking for the payoffs from the federal government, which was associated with meaningful use, which 4 years ago or 6 years ago, I believe the definition meaningful use was use that is meaningful. And now it's gone the exact opposite direction, where meaningful use requires so much that, as you stated, they're not going to bother to hit those marks anymore. It's not worth it for them. So how is this going to come into play? Some organizations will use this, will institute an electronic health system for a lot of different purposes, including research. But a lot of them are just going to say, we're going to do the bare minimum that's going to be required, nothing more, nothing less, and we're going to get more or less what we pay for, which is nothing more, nothing less. So how do you overcome that?
I wish I had the answer, in which case I'd go back to Washington. But I think that there are certain directions that are moving us towards some resolution right now. The emphasis on accountable care, and I will be the first to say that the accountable care legislation needs to be revamped, and they are revamping it because it's quite onerous. But providing the delivery system with incentives to essentially manage their care within a budget, and I'm not calling it capitation, because it's managing it's managing the care that people need within a budget, and then giving them the tools to do that. You know, capitation back in the 90s was impossible because, or didn't work because, it wasn't impossible, they did it, but didn't work because there were no tools, there's no information, and there was no emphasis on quality. So things have changed now, and I think these accountable care organizations are going to move forward with the kind of health information technologies they need to be successful in an accountable care environment, because all the payers are moving in there too. It's not just the feds. And you've got Medicaid, multiple states moving in there. What will it take to get them to provide information for research? I think that's where the research community is going to have to figure out, well, what does it cost now to get data, and what would it cost to work with these systems to get data out of these systems? And it's going to be, it's still going to be about the dollar. But I think that there will be players who will have the information, have the data that you will need because of these accountable care arrangements, which a lot of this is faith. But you're going to have faith in something these days. And as far as healthcare is concerned, I think that's a better alternative than what we've had in the past in terms of payers managing everything.
Other questions? Well, Wendy, do you have one?
Yeah, I thought I might follow up on these all-payer databases, which are, at the moment, an example of aggregated data that can be accessed. And you asked, does anyone realize that your data is in there? The public, as I recall, when this was first adopted, there was a requirement for patients to agree to have their data presented, and then quietly on July 4th, the state put in a little regulation saying, well, never mind with the consent, we'll just take the data. Are we thinking of...
True.
Yes. The kind of data aggregation here, the question comes, to what degree is the data identifiable? Because so much of data that's useful for research needs to be identifiable to track. And has there been much voice from the patient consumer perspective to talk about that?
Number one, I don't think too many patients really understand what's going on. As I said, most of them don't have an idea of what their payers know about them, never mind that all the data is in one big database. I do know, having just come back from a meeting in San Diego at the National Association of Health Data Organizations, that this issue of patient privacy and confidentiality is huge. And in this current environment, the APCDs are very conservative when it comes to patient-specific data. There are some states, like Rhode Island, that have a lockbox on their APCD. So you can go into the APCD, but it's all de-identified, and you have to have special permission to go through a lockbox to get to that data, and that lockbox is governed by patient consent. And there are other states, as I've said before, that don't allow anyone into the data unless, but they will do the analyses for you. You can't, and when you get those analyses, they're de-identified. So the real research, to get to the research capability, you have to know which states will allow you to do that. Maine will allow you to do it. Massachusetts will allow you to do it. Minnesota will. Oregon will not. And all of that information is available on the APCD website, which is apcdcouncil.org, if anybody is interested. You can see which states will allow you to do research at the patient level there. But you're right, there aren't too many.
Jim?
So Karen, Jim Burgess from Health Policy Management. So I've been involved in these things a lot, and I've interacted with you a small amount in some of these things that we've been doing with this. And as a non-physician, one of the things that's really challenging me, I'm surprised you didn't mention, is this question about whether physicians really want this or not. And I'm especially interested in this question around docs and the sort of onesies and twosies that don't seem to me can survive in this new world. And so they're going to have to, connect up, into these bigger systems. And as you go around as a physician talking to other physicians, what do you tell them about that? And is that really is there some way that, or do we just give up on this small physician office?
The most frequent comment I hear in that ballpark is, thank God I'm not any younger.
I know, I hear that too.
Yeah. Most of them are trying to hang on to retirement, or they are joining these larger groups. Now, having said that, there are parts of the country where that just isn't possible. And 2 weeks ago this Friday, the Secretary of HHS dropped a large grant proposal, a large RFP called the Transformation of Health Practice Initiative, $700 million, and it's designed for these small late adopters. Let's call them late adopters. Unfortunately, it was not for the late adopters. It was for these big organizations like big integrated delivery systems, like the quality improvement organizations, like the regional extension centers, like regional collaboratives, to go in and work with these docs to tell them to change. The other problem with it, and I'm still grappling with this because a lot of people have been asking me, how do we do this? Is that it looks at these late adopters in a vacuum, doesn't understand that they're part of an ecosystem that involves payers, that involves sometimes a community hospital and community-based organizations, and also has no specific incentives for these docs to make any changes. So if the inference is that these organizations are going to come in and tell these late adopters what to do and how to do it, I can't believe that it's going to be successful, because we've not been successful with meaningful use in that arena. It is true, a lot of physicians now have something, even if it's just a cloud-based EHR and they pay $100 a month for. Most of them have something like 80% or more, 87%. Most of them, however, do not have a really full functional EHR so that they don't need to use paper anymore, and it takes care of all their patient-related problems. So I'm really concerned about them. I think that they will they'll either retire or in some size, shape, or form be part of a larger system. And there are people who are talking about virtual ACOs, bring them all under a virtual umbrella and see what happens. But you need really good telehealth to do that, and you need really good interoperability to do that, and we're not there yet.
Okay, thank you so much.
Thank
I
you.
have to say,